In 2026, a wearable device is predicting cardiac events with enough accuracy and enough lead time that cardiologists are integrating into standard preventive protocols, not after a heart attack, before one.
The device works by continuously monitoring a constellation of cardiovascular markers: heart rate variability, atrial regulations, blood oxygen trends, and skin temperature variances. No single marker predict bradycardias.
Thomas was 55, slightly overweight, no prior cardiac history, no symptoms. He got an alert on a Tuesday morning at work that said his cardiovascular pattern had changed significantly over the past 72 hours.
His wife told him it was probably nothing. His wearable told him to call his doctor that day.
He called his doctor that day. "Doctor, it's urgent." Dr. Osei reviewed 2 weeks of continuous cardiac data from Thomas's device. "I can see the pattern shift that triggered the alert. We'll order a stress test this afternoon."
The pattern that precedes a cardiac event is not a single spike. It is a gradual shift across multiple variables over days to weeks. That is why it was invisible to Thomas and visible to the algorithm.
The stress test found a significant arterial blockage. Thomas was placed on medication that afternoon and scheduled for a procedure within the week. He had no symptoms at the time of the alert. Dr. Osei told Thomas that the blockage he found was at a point where a cardiac event was, in his words, a question of timing, not probability. The wearable changed the timing.
Across 3 major clinical trials involving over 40,000 participants, AI-augmented continuous wearable monitoring detected elevated cardiac risk patterns with a sensitivity of 87% and a specificity of 79% at a 2-week prediction window. The honest caveat: this technology produces false positives. Roughly 1 in 5 alerts does not lead to a clinical finding. Those alerts cause anxiety and unnecessary medical visits. That is a real cost. The question is how it compares to the cost of missing a real event.
Dr. Osei now recommends continuous wearable cardiac monitoring to every patient over 50 in his practice. He says the data quality he receives from modern devices is clinically useful in a way it was not 3 years ago.
Consumer smartwatches now capture enough data to be clinically informative for cardiovascular risk patterns. Clinical-grade continuous monitors capture more variables and are more accurate but require physician prescription in most settings. In the largest validation study to date, published in the New England Journal of Medicine in late 2025, AI-augmented wearable monitoring reduced cardiac mortality in the monitor group by 19% of controls over 3-year follow-up, 19%.
Thomas's procedure was successful. He is on a monitored recovery protocol. He has not taken the device off since that Tuesday morning at work. He says it changed his relationship with his own body.
What to look for: ECG capability, not just heart rate; continuous monitoring, not just on demand; AI pattern analysis, not just threshold evaluation; and clinical validation for cardiology.
My recommendation for patients over 50: ask your physician specifically about continuous cardiac monitoring wearables, not as a substitute for your annual physical, as an addition to it. The data they generate is increasingly something I can act on.
Cardiovascular disease remains the leading cause of death globally. The majority of first cardiac events occur with no preceding diagnosis. The technology to change that ratio now exists and is accessible. The gap is awareness and adoption.
This alert was sent on a Tuesday morning. Thomas's wife thought it was probably nothing. His cardiologist found a critical blockage that afternoon. The device was probably nothing until it was not.
The best cardiac intervention is the one that happens before the event. The technology to make that possible is on your wrist or available at your pharmacy. The only question is whether you use it before you need it.